Hi, this is Bose Hamill of the Cullen Eye Institute in Houston, Texas, and today I'll be discussing iris repair utilizing a McCannel suture technique. Here's the situation. This patient's undergone attempted cataract surgery, but unfortunately during the procedure there was iris prolapse and iris damage, as can be seen here. I've already implanted a secondary IOL, and I'm indicating the cut edges of the pupillary sphincter, which will turn out to be important landmarks. Here I'm using an intraocular forceps to see just how much mobility of the iris I have to determine whether or not I can proceed with primary repair. The repair begins by joining the edges of the cut sphincter. This is a 10-0 Prolene suture on an STC6 needle. I'm entering through a paracentesis, but then exiting somewhere near the limbal cornea. It really doesn't matter where. After pulling the needle through, and you need to watch the trailing end of the needle and make sure you don't push the lens out of the way, you retrieve the suture ends through the corneal wound. This is a button hook, but a Sinskey hook works just as well. To assist in tying the suture, I'm using an intraocular forceps, which allows me to tie the knot without pulling the iris all the way to the corneal wound. Now once the knot is tied, and I use a 3-1-1, I cut it long and pull it through a paracentesis 180 degrees away from the main incision. This allows me to put the iris on stretch so I can determine where the more proximal sutures need to go. And here I'm passing another suture across. This process is repeated until the iris laceration is completely closed. Again, you'll notice I'm using an intraocular forceps to assist with snugging down the knot. Again, a suture is passed across the anterior chamber, catching both edges of the iris. Be careful you catch good iris tissue so that you get good apposition. For more proximal iris defects, you can actually do the closure through the main corneal wound. You'll notice there's an area of pigment epithelium loss which would result in a transillumination defect and possible additional glare. So I'm passing another suture across this area, plicating the iris to close this defect. At this point, the iris defect is relatively well closed, but you'll notice the pupil is small and decentered. So in order to try to center the pupil and enlarge it a little bit, I'll be creating sphincterotomies. These don't need to be large cuts, just through the iris sphincter, which will allow the iris to pull on the pupil and enlarge it. It's far better to make several small sphincterotomies than one that's too big. I'm attempting to shrink the iris a little more here with the intraocular bipolar cautery, which will cause iris contraction and move the pupil in the direction I want it to go. What I'm trying to do is enlarge it and move it a little more temporally. As you'll notice, the pupil's moved, but not as much as I would like. So I'm going to enlarge the sphincterotomy a little bit in the direction I want the pupil to move. In this case, I'm going to create yet another small sphincterotomy in an attempt to get the pupil to move in a more temporal direction. In order to get an idea of what the post-op pupil will look like, I put Helon in the pupillary aperture, which expands it and mimics what will happen over the next several weeks as the iris naturally retracts. While not perfect, the goal in these cases is pretty good, and this pupil is centered and round.